And we're live.
Okay.
Awesome. Hey, everyone. Welcome. I'm Scott Cohen from AGP Ventures in Boston, along with David DeHeed based in Renana. Welcome to our latest edition of AGP Access, which is our series aimed at connecting Israeli entrepreneurs to the U.S. market. By way of introduction, if you don't know AGP, we're an early stage venture capital firm. We invest exclusively in Israeli startups based in Boston and Tel Aviv. And our mission is really to connect Israeli founders to the U.S. market. And one of the ways we do that is through interactive forums like this. And we're honored to have with us today the amazing Dr. Justin Graham, who's head of informatics and clinical strategy at Walmart's super secretive store number 8. I met Justin probably over a decade ago when he was chief innovation officer at Hearst Health, where he was doing kind of very cool product innovation and launching new products and businesses for the probably $12 billion media and information services company at Hearst. But he's also served as senior product strategy, chief medical officer roles at places like Anthem and North Bay Health and Gyant and a bunch of other kind of leading healthcare companies. So we're honored to have him join us and spend some time with the Israeli startup community. So Justin, welcome and thanks for joining.
Thank you. Thank you, Scott. I appreciate it. It's always great to chat with you.
I like to say I learn something new every time you open your mouth. So for those listening, first of all, we run a really kind of informal shop here. So David and I are going to kick off some questions to Justin, but our goal is to get your questions answered. So pop them in the chat, text us if you're part of our WhatsApp founders group, and we'll do our best to get your questions posed as we go. But Justin, maybe you can just start a little bit with your background. You're a doctor who quickly fell into the healthcare IT world. How did that happen?
Yeah, this goes all the way back to medical school, which don't want to date myself too much, but was in the beginning of the internet era, if you can believe that, if any of you can remember that era. And
don't look old enough.
Yeah, in medical school, I was one of the early adopters of this new web technology, the internet, But as a medical student, and it was at UCSF here in the San Francisco Bay Area where I live now, your main job as a medical student was to run around and run errands and bring papers from one part of the hospital to another and fill out forms. I mean, that was really what the hospital couldn't function without the medical students being the information system of the health system. And so one night I'm sitting there filling out discharge paperwork forms on carbon copy paper, if any of you even know what that is, where it's this piece of paper with this onion skin paper with this thick layer of blue carbon underneath, and you write really hard so it passes through to the next paper underneath. It's so dated, it's crazy. Even then it was dated, and I'm thinking to myself, okay, at home I'm using a word processor, I'm just starting to send email. Why am I doing this in the health system? And it just got me realizing this is an area, such a tremendous area for opportunity for bringing in information technology to transform how healthcare is delivered, and let medical students learn how to be doctors and not be, the sneaker net for the health system. So that started me on my journey, Scott. I had the hubris, of course, this was the late 90s. I had the hubris of thinking I could get the system transformed in just 5 to 10 years. However, still today, we're still heavily dependent. The number one user of fax machines in the world is the U.S. healthcare system. We're still filling out pages of paper by hand. So unfortunately, it hasn't gotten as far as we would have liked. But so following that, for the rest of my medical training, I made the study of informatics, as it was then called, or digital health, a main part of my career, as I studied internal medicine and then infectious diseases. I got a master's in informatics at Stanford, and as a capstone of that, I did a research project to try to understand how we could use algorithms, like the beginnings of what we're now going to be called machine learning algorithms, to look for signs of a respiratory pandemic spreading through the U.S. population through simulated models, and trying to think. At the time, we were like, this probably won't ever happen in our lifetimes. So it was amazing 20 years later to be living in my own research project. But from there, went on to do a lot of work with implementation of electronic health records, working with Kaiser, working with Medicare, which is the large government insurer in the US. and then becoming the chief medical information officer, like the lead doctor in charge of making sure systems are clinically appropriate and relevant and implemented through a number of health systems in California, making a switch from being more on the direct provider delivery side to thinking more in terms of new product innovation, in part because the health systems I felt like weren't moving fast enough, and my impact was so limited being at a single health system to just a small system, as opposed to focusing on something maybe transformative that could be done through innovation on a product level that could maybe spread, nationwide or globally. So that was when I joined Hearst Health to become their chief innovation officer. That's when you and I met. And in that role, Hearst Media is a large media corporation that may be better known in the U.S., although I know they do a substantial amount of investment in Israel, I know as well, Scott. But they're known for high quality editorial content historically in magazines and newspapers and TV stations, but they made a big bet on digital health in the 90s and now own a number of very large, well-known digital health, primarily content companies, First Data Bank, Zinx Health, Millennium Care Guidelines, Home Care Home Base. And in my role as Chief Innovation Officer, I helped identify projects and concepts that were not getting the attention they needed in the individual businesses, and tried to do the full sort of end-to-end lean startup approach of identifying who the proper customer segment was, value proposition design, a lot of design thinking workshops, and then trying to identify sort of what the high risk technology things we had to figure out, and then building pilot programs to test our hypotheses and de-risk these ideas and get them ready for scaling by the individual companies. And we want things diverse, medication prioritization, NLP tools in the pre-chat GPT era to read through clinical notes and help case managers overturn denials of care from health insurance plans. We worked on the bundle payment program that was then taking off in the US. We worked on home health scheduling and routing. So a real diverse set of things that befitted the diverse innovation portfolio at Hearst. And I was there for nearly 6 years in that role. And that was, I got a lot of exposure to a lot of the different things. Hearst is a great place for really trying to start things from innovate and work with all the different aspects of the company. There, I did, in addition to doing some consulting work for companies like Apixio and Doximity. One of them was a physician social network. One of them was focused on using AI to enhance at-risk coding for health plans to try to get better payments. We can talk about that in a minute. And then 2 years as chief medical officer for a smaller startup focusing on digital door chatbot tools for systems, primarily focusing on optimizing triage and reducing the burden on the call center. This was particularly useful during the heady days of COVID when you didn't have people coming to work and you had a lot of people needing the health system and huge demand for vaccine. It was pre-LLM, pre-GPT technology. And I think the technology somewhat leapfrogged a little bit, but we were there at the very beginning, and I think we designed the use case. We actually designed some tremendously valuable content that I still think holds up better than what OpenAI has. And then for the last year, I've been at Walmart, where I've been helping to run a stealth innovation program inside of Walmart, focusing on enhancing Walmart's ambitions in the healthcare domain, and trying to think about how Walmart can have an important role to play in improving the health of the communities where Walmart is. Walmart's in thousands of
questions. Let me ask you a question about this, which, first of all, it's an amazing journey. I love your reference to faxes in the U.S. healthcare system. Israel is like one of the few totally digital healthcare ecosystems in the world. Like 100% of medical records are digitized for everyone. So for them to hear we're still faxing here in the U.S. is kind of embarrassing.
We were faxing stuff years ago.
Yeah. So I'm curious. So like maybe especially for the Israeli startups specifically who know as Walmart as a retailer, like why are you at Walmart? Like, why does Walmart have aspirations to even play in the healthcare space? And what I mean, I know that like your work is kind of super confidential. You can't talk about it, but just at the high level, like why was Walmart playing in the space?
Yeah, sure. And I want to take pains to say I'm not here speaking on behalf of Walmart or anything like that. But Walmart is really, has always been interested in the health of its communities. It feels like it's an important part of the communities there. I think it's public knowledge that there's a growing program to implement clinics in Walmarts. So there's 40 or 50 geographic locations, and soon to be more, where Walmart operates primary care clinics, dental clinics, right there in the store. Incredibly convenient for people for whom going to Walmart is a key part of their weekly or regular shopping. And Walmart touches a lot of communities where they're not the most well communities in America, where we have actually in America there's the healthcare crisis in those kind of communities. A community where people are not getting enough healthy food or can't afford it. People are not getting, there's high rates of obesity, high rates of mental health issues, high rates of chronic disease. And I think Walmart is starting to realize it has a role to play in helping that community. And that just benefits both the community and it benefits Walmart to have healthier, more robust communities that those people end up buying groceries and they end up it ends up being it's sort of a win-win for everybody. So, Walmart has talked about this publicly, and they've engaged in, like I said, we're building clinics. There's been a publicly announced a partnership with United Health around value-based care. Walmart's also gotten into the clinical trials recruitment space through our Health Research Institute. I know Sam Walton, who was sort of the legendary founder of Walmart, had a great deal of interest in trying to bring sort of Walmart's level of efficiency and transparency around pricing, and low cost, high quality to healthcare. And that was one of the things I think, I've heard was on his mind in his last days of life, last weeks of life. And I think Walmart's doing what it can to that. And then within store number 8, that's like the Stealth Innovation Group, works on a lot of different projects. I'm going to be on the healthcare group there. And we have some ideas around how Walmart can have a very unique, differentiating and really interesting opportunity to support those efforts. Can't talk too much about that here, unfortunately, Scott, but it's been an interesting journey. Yeah.
Sure. Can we let's zoom out a little bit, just because I think you're tapping into something that I'm not sure most of the Israeli entrepreneurs can understand in terms of this dynamic, which you've explained to me in the past, of healthcare moving closer to the home. That there seems to be this trend in the U.S. where health is migrating kind of away from the kind of central, hospital systems and more kind of closer to homes and kind of the retail environment. Can you like in broad brushstrokes kind of explain a little bit like what's happening in the market in the U.S. and kind of the trajectory it's on?
Well, in general, the healthcare system in the U.S. is like this incredible. It's incredibly complicated. We don't have enough time at all to kind of go through the complexity of it. But it's in many ways it's a story of sort of two different healthcare systems. On one end, if you've got money and resources and great insurance, and you get sick, particularly with something unusual, rare, or a cancer or something, you can get world-class treatment. I mean, this is why people fly from all over the world to get their, oncology treatment at the Brigham and Women's, or come to UCSF for neurosurgery, that kind of thing, or get their organ transplant at Stanford. On the other hand, if you don't have a lot of money, if you are, in that underserved population, we have some of the highest rates of preventable chronic disease in the world. We have maternal mortality rates that are abysmal for the developed world, and we do so poorly on many different metrics, particularly having to do with populations that have access to higher quality healthcare. And on top of all that, we have like the most expensive healthcare system imaginable. This is because it's just the unique confluence of the way how things came together in America to deliver healthcare. It's really a very complicated intermingling of multiple different kinds of systems, where you have a government-based insurance system, but you also have a private for-profit insurance system that's commingled with it, and you've got lots of different individual healthcare systems. Most of them are non-profit, but really act like for-profit entities, and then the doctors are often quite separate from them. Then you've got, of course, pharmacy, which has like these miracle drugs, but they've also figured out how to make just obscene amounts of money off of them. And you've got intermediaries every step of the way, like pharmacy benefit managers and everything. So there's just incredible complexity. This ends up, focusing in many cases on profit over patients, and the really profitable items tend to get a lot of attention. The things that are not as profitable and sexy, say primary care for chronic disease management for an underserved population, which has really very little profitability attached to it, tends to get under recognized. And so you have this giant gaping hole, for instance, in the communities where let's say retail may have to play a role, not just Walmart, but all the other retailers who are going into these primary care specialties, primary care, recognizing that primary care is really kind of underinvested in, underserviced, and it's really the gateway to trying to prevent some of these long-term complications. We have this weird thing in this country, Scott, though, where because we have this incredible amount of investment in this high-end care, the oncology care, the complex cardiac, interventional care. Well, of course, the dirty secret is if you invest a lot in primary care and prevent all those things, then you have fewer lucrative procedures, right? So, and then there's less money to be made in healthcare. And so, but because everybody is sort of like the tragedy of the commons. I mean, one of those classic economics thing where each individual actor is just optimizing for their own personal benefit. And so even though investing in primary care may be a money loss for that primary care, it's probably a net benefit to the community. But, the people who are making cath labs and neurosurgical devices and expensive medications don't make any money on that. So they're not, they're not.
Right.
Yeah.
Right. It's super complex. Let me kind of zoom back in from the macro to some of the micro in terms of like your kind of some of your strategies. So like you've kind of spent a lot of your career like building and delivering kind of early stage healthcare products. Like I'm curious if you have any particular approach to kind of success in that space. It sounded like you guys were deploying lean startup at Hearst. But I'm just curious, like, is there a general kind of approach that you've taken as you've built out some of these early stage health products?
Yeah. It's a great question, and I'm still learning too. So after all these years in the industry, I just want to let you know it's just so complicated. It takes years, but I think a couple things to keep in mind as you enter the U.S. healthcare market. One is you really understand the specific market segment you are looking at and what problems they're facing and what your solution is going to offer over the next best alternative, and really get focused. You can't just say, I'm going to make a product for doctors, because honestly, like how a orthopedist runs his or her office is going to be very different from the way, say, a multi-specialty clinic works or a fully owned primary care office. Like it's really, these sub-segments are really important to understand. And you may not know at the outset what you're going to do, but have a plan to narrow your focus and understand what that market's specific needs are. One size fits all doesn't really work so well in healthcare in America. Secondly, I hate to say it, but you have to follow the money. Things that seem like they are terrific quality of life improvements or improvements on patient care are great, but they have not proven to be commercially successful for the most part. You may think this'll, I've worked on projects that, we thought, okay, this'll save an hour of time every day from the nurses, work at the hospital. And then you talk to the people who have to write the check, who are not the nurses, they're not the users. It's someone else who writes the check. It's a person sitting in the back with the spreadsheet who writes the check. And that CFO or CIO says, well, that's great. What am I going to do with that hour? Like, doesn't save me any money. I still have to I can't just lay off an hour's worth of time from, somebody. So they're like, we're not going to invest our time and money and energy into your product because there's just the ROI is so minimal. Another rule of thumb, don't underestimate the complexity of getting these things up and running, even a small pilot. I would actually avoid pilots that don't get paid, by the way. That's another story. But working with U.S. Healthcare entities, extremely conservative, extremely slow to move. They are very conservative around security, privacy, and confidentiality, and you better have all of your I's dotted and T's crossed, and be 100% able to pass security audits and with anything, particularly if you're touching any patient data whatsoever. And implementations can be quite challenging because IT departments within health systems, particularly if you're talking about health systems or even payers, the IT departments are overburdened, have a huge backlog of projects. Even if your project is super important, your project might get delayed a year or two, and because they have other things backlogged. And the IT folks who end up in health systems are good people, but they may not be sort of top innovators around optimizing around getting things done. And sometimes you may find there's some inertia, or somebody who's been running some interface system for 20 years, and they're kind of gruff about this newfangled way of doing things, and then they may put up barriers. So you have to be careful about that, and you have to you really should come to the table with an extremely compelling value proposition that solves a burning problem to try to overcome some of those hurdles, because otherwise you get caught up in a lot of inertia. And another thing I'll say is, particularly if you sell into health systems, and academic health systems can be the worst about this. If you have a meeting where you try to get buy-in from stakeholders, in many healthcare organizations, there's no one person who can say yes. It has to be yes by a community of people, and any one person just saying maybe will slow you down by 6 months. You'll go to that big meeting, like to get buy-in and approval, and one person in the back says, I'm not sure, maybe someone else can, maybe my cousin's working on something on his Excel spreadsheet, you could do this, maybe we should do that. And I'm not joking. Then they're like, okay, well, we'll have another meeting in 2 months to work this out. And then you're like, what the heck? So that happens all the time. You have to be ready for that kind of thing. It really helps to have a really strong champion on your side when you go to a health system. I don't know, Scott. We could go. This
is amazing, and I'm getting. So if you see me looking down, I'm getting all kind of texts with questions. Okay. So if okay, I'm going to throw some of these out.
Yeah, great. Yeah.
You mentioned pilots, like you said. You just mentioned, like, don't do them unless you get paid. So I got one text that says, I come out of the cybersecurity market where pilots were common. My new company is in healthcare, and I get the sense U.S. providers don't want to do pilots. Is that true, and is there a way around that?
Yeah, I think I tend to it's not universal, and there's certainly circumstances where a pilot makes sense. So it's not set in stone. But the problem with doing a pilot that is unpaid, you got to really think, what are you getting out of this? So first of all, you're not really proving your marketability value proposition, because anyone can take something for free. Secondly, you get caught in these like endless bureaucratic cycles, and then growing, so many times I've seen a pilot that even seems on paper to be very successful go nowhere, because nobody has. You've gotten over the inertia to get the pilot in. You'd think that would get you over the inertia to go further. It doesn't get you anymore. You have to go back and do the same amount of work to get the pilot expanded. So you might as well start with something that you're actually able to like grow immediately. Now, land and expand is a reasonable strategy for growing in healthcare, but I usually think going in with something that's paid. Pilot is early stage product. We're still trying to learn about things. It's fine, but I think you should be really careful about just calling it a pilot, because otherwise it's just easy for people to just say no, we're not going to do it. And I've just seen too many pilots just become nothing, become an end in of themselves. You're spending all this time on a pilot that's not getting paid. It takes forever, and at the end of it, you're no closer to actually building your business any further, and you've gone off to some other thing. But the last thing I want to add, Scott, that's really important in the U.S. healthcare system is it is a real cottage industry, and how we have lots of health systems and payers, and how one of them does business is not like how any other one does business. And the workflows are different, and the job descriptions are different, the job titles are different, and the processing and the technology. And so if you've optimized for something at the Mayo Clinic, and then you go to Duke University Health, they're going to say, well, we don't have a care coordinator that does this job, and like our data goes in an Epic system, it's a server system, and by the way, this project conflicts with so and so's program. We have a rehabilitation program that they don't have at the Mayo, and like you're having to like customize everywhere you go. It's a real trap that a lot of startups fall into, because you want to get customers and you want to go live, and you're like, okay, great, whatever you say, I'll just customize for you. And then 6 months, then maybe you get some success, and then 6 months down the road, a year down the road, you've built a consulting firm that's done custom one-off software instead of reusable, repurposable SaaS business, like software business. This happened to us at Gyant, it's happened to us other places where you build all these one-offs, and then you have forked your code. You've ended up with completely different things. So you have to be really vigilant about that and try to stick to your guns. It's challenging because everybody wants customers and revenue, and you don't want to say no to your customer. But it's a trap in the U.S. healthcare system. It's a trap you can fall into.
Wow.
I have a quick question before we go off the pilot topic. Every Israeli startup is kind of starting a pilot in Israel with a hospital here. What kind of pilots are transferable to the U.S. versus which ones, having a pilot here means nothing in the U.S.?
Well, in terms of credibility, it's going to be a limited credibility, because there's going to be a lot of not invented here, not in the U.S., even if it is applicable. So in terms of just perception, whether or not it is applicable, you're going to get that. You're like, well, what? Okay, Israel. I know nothing about Israel, and I know nothing about Israeli healthcare, and it's got to be completely different. So I can't trust you. Okay, so that's one thing to be careful. That's not universally true, and some things that have done really well in Israel have made that transition here. What I'm thinking, well, Taito, which is more of a device service thing, but there's a few others. I think I'm just blanking right now. I think if you can demonstrate, it really depends. Sometimes some of these things are more administrative, some of them are more clinical, some of them are devices, some of them are other things. So it does depend a little bit. Things that are about human physiology and, like a device to measure human physiology, like you're humans everywhere, so that's okay. You will need to get the appropriate level of approvals here and through the FDA here or whatever for those kinds of things. I have less experience in the device diagnostic space. That's not my field so much. When you're talking about digital, I think people are going to really want to understand, people are very conscious how the workflow over there, like they won't even trust what you did across the hospital across the street. Then you start talking about something that's thousands of miles away in the Middle East, and they're going to be like, okay, I don't think it's valuable at all here, even if it is. The workflows here are really, my understanding, are quite different. I've only heard anecdotally about the Israeli healthcare system. And by the way, I have a great respect for the Israeli healthcare system. I think it's a great model with the competing HMOs. And I don't know, maybe you guys don't think it's as highly as I do, but I of course think there's probably most healthcare systems in the developed world are better than our healthcare system. But I love that model. But you really only are working. I think you guys are only working towards maybe 3 or 4 major players in the system who all kind of have. Even if there's 4 different ways of doing things, there's only 4 different ways of doing things. And in our country, it's like 100 different ways of doing things, or more, hundreds of different ways. We can even talk about the differences in state laws and things like that. So we have 50 states. Each of them have their own regulatory environment. It's amazing that anybody wants to ever even do business in this country.
Totally not.
Yeah. So I think some of it you just have to think about the specific use case. If it's really deep in the weeds of like processing, paperwork or workflow, like people are gonna be much more skeptical than maybe something that's. I've got a device that help manage knee rehabilitation after surgery or something like that. Well, okay, knees are the same or all. Might be wants on that as long as you approve the clinical process.
So Justin, let me, David, do you mind if I ask a few more questions?
Yeah.
I think we're slated to go for a half hour. We're at the end of it, but like, if it's okay, Justin, I've got a couple more questions that have come in.
Yeah.
I mean, I got a bunch more, but I want to throw in a few. So,
sure.
I'm not even sure if you can answer this, but Justin, who tends to be more innovative and fast moving in the U.S., payers or providers? And here's the kicker: are there any specific entities or regions in the U.S. that tend to be low-hanging fruit, where startups can kind of prove their value, prove their worth?
Yeah, great questions. I think there are pockets of innovation all over the place, and it's just you got to find them. I wouldn't say payers or providers. There's more diversity in the provider space because there's more providers. I mean, we have the payer marketplace in the U.S. is dominated by the top 6 or 7 payers, or we have government. We don't have time to kind of go into how this all works, but there's government side payers, and then there's private payers, and some of them are operating government programs, but whatever. But the private payer landscape is dominated by a handful of firms, and then there's a long tail of small firms, smaller companies. But the provider space has got hundreds of different players in it, and again, different verticals, not just hospital, not just doctors. There's also home health, and there's pharmacies, things like that. There are pockets of innovation all over the place. You got to find them. So I don't think I'd say one or the other is necessarily more or less innovative. And some of them are more conservative than others. But I would say, in answer to your second question, I have found as an innovator, the place to go to find someone who's willing to take a chance with new offering, because what you're doing is brand new, and so you do need to find someone willing to take a chance. I have found middle market underdogs are really a great place to start. If you go to the biggest players, they tend to be more bureaucratic, and they have either too many problems, or your problem is too small for them to work on, and they also think that they can sometimes solve it themselves. So these are the big health systems in America. If you go to the tiny health systems, they don't have any resources. You've got one person who's both the chief information officer and the chief financial officer and the CEO of the hospital is like running around. They're trying, they just don't have with and resources. The middle market players who are being edged out by their larger competitors, who are trying to prove themselves, who don't get a lot of people knocking on their door with new ideas. They might be in parts of America that your Israeli team doesn't know a lot about, middle America, states that, Iowa or Minnesota, Nebraska, who are outside of the cities, but with a substantial geographic reach, but maybe a 2-hospital system that's got to try to keep the big players out and trying to keep their programs afloat. They're looking for an edge. And I have found them to be very open. Like, they don't get people knocking on their door because everybody's going to knock on the big academic healthcare systems, whatever, going to Mayo, Stanford, and Harvard, whatever, and not talking to them. And they're actually really open to those conversations, and they're more functional than the really tiny ones. So that's my secret tip to go after. You'll have to figure out which ones those are yourself, but and there are lots of them. There's thousands of them in the U.S. to go after.
Yeah, that's great. That's great insight. All right, let me throw 2 more questions over the wall to you. I'm combining 3 questions into one, which are there are 3 questions about basically about AI and ChatGPT, which I'm going to kind of summarize as what are your perceptions about how leading healthcare companies are thinking about AI and ChatGPT? Specifically, I think there's questions are asking, is there kind of an internal resistance and hesitation around AI and ChatGPT right now, or is there kind of an eagerness to adopt and test? What have you seen in large healthcare companies so far?
Yeah, everybody's paying attention to this. This is, and if you aren't playing with a language model and testing it out and trying to use it as part of your regular work, you are behind. It is really phenomenal what these things can do. I don't want to oversell because they're not perfect and there's lots of problems, but man, it's evident to anybody who plays around with these language models how powerful they're going to be. I think a lot of people are. I'm not involved in other health systems other than what we're doing in Walmart, but I know everybody's sort of trying to figure out what to do. How there's a lot of concern around data safety, privacy, security of data. So I think that's probably the number one thing I'm hearing from just folks who are in health systems, which is okay, I really want to use this, but how am I going to keep it Like, how am I going to satisfy my confidentiality obligations to my patients? If we use patient care data, how am I going to know someone's not going to use this information that we put in there, even if it's not patient data, use this financially in some way? Like, someone's going to game my system and steal my lucrative patients or whatever, because again, profit is sort of the king in American healthcare in many places. And there's a lot of experiments going on. Nobody's like in every industry, no one's quite sure how this is all going to shake out. Is this all going to be, everybody's going to be running everything through an OpenAI API, or are we going to have these locally customized models, or are we going to, is there something completely different that's going to come out of this? Are there these medically specific models? I think there's a lot of incredible interest, and I don't think anyone can accurately foresee exactly how it's all going to shake out, but it will be a feature of anything. I personally am most excited about the idea of this is the new user interface for healthcare, is language. Leaving aside like specific use cases, healthcare providers in general, like, and I think just average non-technical humans, we've all sort of learned how to use a keyboard and mouse around and kind of get things done. But really, the future, it may not be 2023, it might be 2, 3, 4 years from now, but the future is just, okay, bring up my email, tell me which emails are the most important, and rate response, and you're just like getting to the point where you're not the computer, your voice or whatever language, you don't actually have to write any code, you don't have to actually you have gosh, I wonder how many patients I've seen this year who have this condition. Like, feel like I've seen a whole bunch. Okay, they're all like, I don't have to do a query, I don't have to like write code, I don't have to ask a data scientist to look this stuff up. You could think of a million different things. The language will be the way to do things, and maybe on the back end the model doesn't have to be super sophisticated. It's just translating what I'm saying into some code, or just robotic process automation in some way. But that's what I'm most excited about, is like humans interface with each other and the world through language, and then we've created this artificial way to interface with computers through a mouse and a keyboard and a screen, and actually now we're going to be able to interface with the whole information ecosystem through language, which is like the native way that humans interface with the world. So,
right. That's amazing. All right, one last question, which is just, someone has asked, and David, I'm sorry I totally took over this.
Yeah, go for
it. Someone asked, what's the most interesting or cool technology you've seen or played with in the last few months?
Oh, aside from language models, I think the language models blow me away all the time. Language models, and obviously the generative AI, art, which is not super relevant to healthcare, but man, that is just some of the stuff people are able to make. The deep fakes and the video, the live video stuff, and I mean, it's just like, it's so amazing today, and you're like, this is just the beginning. It's only getting better. Other technology that's what's currently blowing me away. Like, I'm seriously, like, every day I'm trying to read like what are the latest incredibly clever use cases people have done, where they're multi-threaded agents and trying to optimize around all different kinds of use cases. So I think I'm trying to think of other areas that are really exciting me these days that are technology driven. I don't know, just that's it from the AI side of things. I think we're just seeing some interesting elements around ability to have better treatments for cancer. I mean, there's some medical elements that I think are kind of exciting too. Just so that there was I'll tell you, a medical development that has nothing to do with AI, but is really interesting, that I saw a couple months ago, blew me away, where somebody did a great natural experiment where they looked at the shingles vaccine being given in England. I don't know if you've heard about this. This was so groundbreaking, and yet it didn't get a lot of press. They decided that people on a given, so they started the shingles vaccine. There wasn't enough of the shingles vaccine. It's treating, the same virus that causes chickenpox. It prevents shingles. This is a painful rash. And they give it to elderly people, and they said, well, we don't have enough. So if you're born on September 3rd, 1950, whatever, and later, we'll give it to you, but we can't give it to anybody who's older than that. Or like, they had some date in England. And somebody said, well, wait a minute, maybe we could just look at, like, how are those people, like, there's nothing different if you're born a week before that date and a week after that date. You're the same cohort. It was just an artificial date that they picked out of a hat. And they found that people got the shingles vaccine tended, after that date, did not get Alzheimer's, or tended not to get Alzheimer's. So it's a very strong core. There's like nothing else. If you were born a week before that date, you were much more likely to get Alzheimer's than if you were born a week after that date in England. Which means that the shingles vaccine is probably preventing Alzheimer's. Which is, yeah. So sorry, that's that little medical breakthrough that it was like, yeah, which is like really Alzheimer's is a massive problem. Man, if any of you have had a relative who's suffered of Alzheimer's, you realize how horrific that disease is and how many people in this country, in this world, suffer from it. And to think that we have a tool right now. So I still get excited about healthcare, not just healthcare delivery, Scott, not just the technology. So.
It's great stuff. Well, look, we're up against it, but it's been an amazing call, Justin. Thank you so much for joining us and taking the time to chat.
Yeah, thank you so much for inviting me. This was super fun. I'd love to interact with your audience if they want to reach out to me or reach out through you, Scott. And this was so much fun. I'm really, really glad I got invited to do this.
Thanks. Glad to do it. We'll definitely follow up with that. So everyone, you've been talking to Dr. Justin Graham, head of informatics and clinical strategy at Walmart's store number 8. I'm Scott Cohen from AGP Ventures on behalf of myself and David Yahid in Israel. Thanks for joining us. And until next time.
Thank you.
Thanks all.